Okay, guys.
All right, good afternoon. We're going to talk about genetic disorders and kidney disease today, and this covers a number of different things, and it's actually one of the more fun talks I give. You're going to find that some of the information here for an internal medicine resident or an internist is a little esoteric, but I guarantee you'll see some of these questions on boards. At the end, we have a few board review questions, so we'll go over those as a group. For those of you that were here last year, I didn't change them, but next year I promise I'll get some new questions in. All right, so this is kind of an outline of what we're going to look at today. We're going to break it down into cystic disorders and non-cystic disorders. And you can see here we're going to do ADPKD, autosomal recessive polycystic kidney disease, tuberous sclerosis, von HippelLindau, and then of the non-cystic disorders, we're going to do hereditary nephritis, then one brief slide on thin basement membrane nephropathy, and then one that is always on nephrology boards. Don't know if it makes it to internal medicine boards or not, but Fabry disease is a perfect one for the people to pick up on boards. So the disease you may see a little bit more frequently than some of these others is the first one we'll talk about, which is ADPKD. And it affects 1 in 500 to 1 in 1,000 individuals, and up to a quarter of the cases are de novo. The gene is PKD1, another gene PKD2, which represents about 10 to 20% of the cases, but most of the cases, 80 to 90%, are from a defect in PKD1. The difference clinically is that patients with PKD1, and they are the majority, they progress to ESRD by about age 55, which is looking younger and younger every day. PKD2 reach ESRD a little bit later in life, by about age 75. All right, so renal complications. Gross hematuria, about 50 to 60% of patients will get this. Infection, about a third to a half of patients. The patients get stones. Of the 25% of patients that get stones, over half of them get uric acid stones. The rest get the standard calcium oxalate stones. They get decreased concentrating ability, and of course the major renal complication is the progression to ESRD. All right, non-renal complication, kind of a long list. These are ones that might pop up in the future. Hepatic cyst, more common in women. They can get diverticular disease, but as you know, a lot of people get diverticular disease as they age, but they believe there's an increased prevalence in ADPKD. They can get abdominal wall hernias a little bit more commonly. Men can get seminal vesicle cysts. Hypertension, of course, is probably one of the earliest and most common complications, and eventually will occur in 60 to 100% of patients. Intracranial aneurysms run in 10 to 15% of families with ADPKD. Valvular disorders, mitral valve prolapse being a common one, but also mitral regurgitation, and then other valvular diseases including tricuspid and aortic valve prolapse or regurgitation occurring up to 20% of patients. All right, if you look up the classic Ravine criteria for diagnosis of PKD, this used to be real simple. There was one Ravine criteria and you had to know that, and it popped up on medicine boards. Now they have multiple different kind of breakdowns of this. This is the one I think you probably need to know. It's the individual that is at risk for ADPKD, but unknown familial genotype. That would be the most common thing, right? You know somebody in your family has polycystic kidney disease, but you don't know technically if they're, you haven't done genetic studies to know for sure if they're PKD1 or PKD2. You may suspect because they all went on dialysis in their 50s, but you may not know for sure. So when you look at their ultrasound, if they're between ages 15 and 39, they have to have at least 3 cysts on one side or between both kidneys. So a total of 3 cysts. They can either be unilateral or spread out 3 between the 2 kidneys. Once they hit age 40 to 59, they need at least 2 cysts in each kidney. And then once they're either 60 or older, they need 4 cysts in each kidney to make the diagnosis of ADPKD. This becomes especially important for people who want to donate kidneys in their family. So if you have somebody that comes up and they're 38 years old and they have 2 cysts, then you have to make a decision. Can they donate, or are they going to go on to develop another couple of cysts in another couple of years, and do they actually have ADPKD? And that might be a patient you would consider genetic testing, but you certainly don't want to have somebody that's going to go on to develop ESRD, donate one of their kidneys if possible. All right, so treatment. Hypertension, gosh, a little bit debatable now with KDIGO, which is our international guideline organization, and now JNC8 have come out. So this is a little bit up in the air, but the traditional goal has been less than 130/80. The KDIGO 2012 goal for CKD patients that don't have proteinuria would be less than 140/90. Interestingly, a lot of people disagree with that. The ARPKD trial is a study going on now. You can click on this link and you can see the different groups. Basically, it's ACE inhibitor plus placebo compared to ACE and ARB together, which is kind of interesting in the current era where we're generally avoiding the combination of ACE and ARB because of side effects and hyperkalemia and other issues. But this study started in about 2006 and will finish this summer. So I imagine you'll see this come out in a fairly major journal, I would think next year or the year after. The blood pressure goals in the ARPKD trial will be very low as about 95 to 110 systolic, or more quote-unquote normal blood pressures, I believe around 130, but there's a range there. All right, so other treatment. If they have gross hematuria, you want to try to minimize the risk. You want to tell them that they should avoid blunt trauma to the back and abdomen. Just out of fellowship, I had a 20-year-old young man who was in college at the University of North Carolina at Wilmington, and he was going to play football there. And it was a big deal. He really wanted to play football, and our classic teaching in my training was that should be discouraged. You know, they're going to do what they decide to do, but it should be discouraged. But you really do want to avoid any major trauma. Urinary tract infection, these often need very long courses of treatment. Remember that up to 70% of cysts are completely walled off from the nephron. So you need these lipophilic antibiotics. They have to cross the cystic epithelia to get into the cyst fluid and to treat the infection. So these are your three key players for treatment. So you notice aminoglycosides aren't on there, piperacillin tazobactam's not on there. So you see an ARPKD patient, you've got to think about quinolones, trimethoprim, and chloramphenicol. And then stones, as I already mentioned, they can occur in about 25% of patients, and about greater than 50%, somewhat more than 50% are uric acid stones, with the rest being calcium oxalate. All right, so moving on to autosomal recessive polycystic kidney disease, so much less common, 1 in 10,000 to 1 in 40,000. This is a malformation complex confined to the kidney and liver. I imagine the folks out there that are med peds are going to be more familiar with this than those of us who are internal medicine. They get ectatic dilatation of their collecting ducts. They present typically in the perinatal period. Neonates can have enlarged echogenic kidneys, and remember this for the questions we're going to do later. They can have pulmonary hypoplasia. That shows up again on our boards. They can have a high incidence of high incidence of hyponatremia, defect when they have problems with free water excretion. They can get growth retardation. Hypertension presents very early in ARPKD, and it's common. They progress to CKD during their childhood years. They get kidney stones, and they also can have pretty big problems with hepatic fibrosis as well as portal hypertension. All right, so next disorder, tuberous sclerosis. I've seen one patient with tuberous sclerosis in my career. She was a dialysis patient with us. And for our nephrology fellows, it always helps to have a patient that you can put a disease with, especially one that's very uncommon. Having said that, this is an autosomal dominant disorder, a little more common than autosomal recessive PKD, but not as common as ADPKD. 1 in 5,000 and 1 in 10,000. About one-third of these cases are familial. We think of Voigt's triad when we describe tuberous sclerosis. They can have seizures, commonly may have some degree of mental retardation, and you'll see facial angiofibromas. Other things that they can have clinically is hamartomatous type tumors. From a renal standpoint, they'll get cysts and angiomyolipomas, and you can even see cardiac, for the budding cardiologists out there, cardiac rhabdomyomas. So one thing to kind of pay attention to is renal cell cancer is not on this list. So tuberous sclerosis, mental retardation, seizures, They can get cysts, they can get angiomyolipoma, but they don't get renal cell carcinoma. These are some photos off the internet. Just to give you an idea, you may be familiar with these, but ungual and periungual fibromas are classic for tuberous sclerosis. The chagrin patch, connective tissue nevus, I think it always helps to see a picture of some of these things that we don't see very often in patients. And then last year when I was looking this up, these are actually ash spot tennis shoes, but the ash spot I'm referring to is the hypopigmented macules. And it's funny because when I Googled ash spots this year, the picture and did images, the shoes didn't come up. So they must not be as popular this year as they were last year. All right, and then some more, there's lots of diagnostic tools by exam as well as imaging for tuberous sclerosis. So they get neurologic and dermatologic manifestations. So here you see sort of a hyperdense area. These are cortical tubers. Subependymal giant cell astrocytoma is here. And then a subependymal nodule, I believe they're directing us to this area. So I guess this is the astrocytoma, and then you've got your nodule here. All right, moving on, next disorder, von HippelLindau. So this is a systemic neoplastic disorder. Remember, renal cell carcinoma, not so much with tuberous sclerosis, but you're already thinking maybe cancer here. So clear cell renal carcinoma, autosomal dominant, 1 in 36,000. Kidneys with a varying degree of cystic burden, so they may have a lot of cysts or maybe not so many. They do not get cyst infections like the ARPKD patients do. Their kidney function, usually normal. Their CNS involvement, which you can often confuse with the tuberous sclerosis CNS involvement, but you just have to keep those separate. Hemangioblastomas in the retina, the cerebellum, and the spine. They can get pheochromocytomas, as you know. And they get multiple pancreatic cysts. So if they gave you an ARPKD patient with hepatic cysts and renal cysts and pancreatic cysts, you know, your ARPKD can get pancreatic cysts, but that would not be a question, a classic question where you would be tested. All right, and then Alport Syndrome or hereditary nephritis. I have a couple of patients with this. Usually this is X-linked, about 80% of cases. They have a defect in the type 4 collagen, the alpha-5 chain on the X chromosome. There are also autosomal recessive and autosomal dominant cases, but those make up a far fewer percentage. Their mutations, as I said, are in the alpha-5 chains of type 4 collagen, the alpha-3, 4, and 5 chains of type 4 collagen. And this is about a frequency of 1 in 5,000 to 1 in 10,000. Their clinical presentation, when it's the most common X-linked disorder, is, and this is in males, of course, is their glomerular disease. So they have a defect in their glomerular basement membrane, and they eventually progress to ESRD. They also sometimes can have abnormalities picked up more so by the ophthalmologist than an internist. They can have a disorder called anterior lenticonus, and they can have sensory neural hearing loss. They may come with a family history of hematuria associated with family members who have kidney failure and who are deaf. And they're often diagnosed by skin or kidney biopsy. I just saw one of my patients with hereditary nephritis this week. And every time we get, if I'm not having a busy clinic, we talk a little bit about, you know, sort of his story. And he reminded me that he was sent to Chapel Hill from Goldsboro when he was about 5 years old. And he's now about 47, I think, 47 or 48. And he was sent there when he was 5, stayed at UNC hospitals for about 2 weeks. And they biopsied him every which way, trying to find out why he would have occasional hematuria. And they knew he had a problem. They advised frequent follow-up, but at that time they couldn't give him a diagnosis. So fast forward, he eventually becomes deaf in his 40s. He eventually went back, I think, in his late 30s and had a kidney biopsy. And so finally he had a diagnosis to go along with his disorder. And he had good family support. And he's fairly educated. He's followed his kidney function all these years. So he's very well prepared with a creatinine of about 2.2. To get a kidney transplant from a family, actually not a blood relative, but I guess an in-law, somebody on his wife's side of the family. All right. Renal manifestations, they can get just simply microscopic hematuria that persists. They can also get episodes of gross hematuria, sometimes after a respiratory infection. Does anybody remember what the other two disorders where patients will get hematuria after respiratory infections? Post-strep, and what's the other one? IgA. So for post-strep, do you remember how long it is usually between the, yep, and then how about for the other? Yep, so days versus weeks. Some people talk about synpharyngitic and sonpharyngitic with the episode or separated from the episode. Often when you're looking at these patients, hereditary nephritis kind of comes in the differential of gross hematuria or microscopic hematuria or both, and can be something that you're bringing respiratory infections into the picture if they notice that they have blood in their urine after a cold. As affected men reach young adulthood, they typically get hypertensive, they have proteinuria, and they progress with their CKD. ESRD typically between ages 16 and 35, so my patient has had a very good course. He's taken excellent care of himself. He argues with me about staying on his ACE inhibitor when his blood pressure is 105 systolic. And he occasionally has dizziness, but he promises me he'll come off of it when if he thinks he needs to, but so far we've been able to keep him on renin-angiotensin therapy. He's done very well. Ideally, you want to treat these patients with transplantation. One caveat is, remember, in about 3% of these patients, you give them a kidney with a normal glomerular basement membrane and they can develop antibodies to it. And so they can get what's called post-transplant anti-GBM disease. So kind of an interesting aside to these patients when they're transplanted. Should you transplant them? Of course, if it only happens in 3%. Does it recur if they've had it once and they get a subsequent kidney transplant? Yes. Does cytoxan and plasmapheresis work very well in this type of GBM disease? Not particularly. So typically they will lose their graft. All right, one slide on thin basement membrane disease. This is also known as benign familial hematuria. Again, we're talking about type 4 collagen defects. They can have microscopic and or gross hematuria, but this disorder is really quite benign, and they typically don't progress to have end-stage kidney failure. And these are patients where we'll have this on our differential, but we don't biopsy them because we may be thinking that they have a very quiescent form of IgA or thin basement membrane disease, but we elect not to biopsy them because they have no significant proteinuria and their kidney function remains normal. But they should be followed very closely, and if they develop high blood pressure, that should be treated. And of course, biopsy if their clinical circumstances change. All right, so this is a fun disorder. I recertified nephrology 2 years ago in the fall of 2012, and this was on at least a couple of questions for us. Don't know if it would be with internal medicine, but still an interesting disorder. It's an X-linked disorder. It's a deficiency of Alphagalactosidase A enzyme. They can get nephrotic range proteinuria. They end up ESRD by their 20s or 30s. They'll describe painful paresthesias in their hands. They can get premature coronary disease. They can often have a CHF type picture that you really don't, it doesn't fit their other clinical presentation. They're young, maybe a family history of young individuals developing heart failure. It almost mimics a hypertrophic type cardiomyopathy. The ophthalmologist may pick up corneal opacities. And now, I don't know when the treatment became available, but certainly within, I believe, the last probably 10 years, maybe 5, we now have IV replacement recombinant human alpha-galactosidase A therapy. So certainly not cheap, but there is now a way to treat this disorder. So if you see somebody who has early CKD, maybe even a family history of ESRD, they've got some CHF that doesn't quite make sense to you, they say their hands feel numb and painful, this may be something to think about. These are the classic findings on electron microscopy. These are known as zebra or myeloid bodies, and they are deposits of the galactosidase in the lysosomes. And this is just a great picture to go along with the case presentation. This is where I was last year about this time. Hopefully we'll be there about next year. These are the maroon bells in Colorado. This was at not the top of the mountain, but this my top of the mountain. All right, so So let's take some questions. I think there's 7, and I think we typically do okay with time. How much time are we good on time? Oh yeah, so we're great. I've got 7 questions. We'll do each of these. Okay. So a 67-year-old male college professor who has ADPKD consults you regarding the need for evaluation of his cerebral vasculature. He is aware of the increased incidence of intracranial aneurysms and ADPKD, and recently he hasn't been sleeping so good. He had a previous ultrasound that showed enlarged kidneys, quite enlarged, 21 and 22.5 centimeters, and multiple hepatic cysts. He takes no medicines. His father died at age 62 from kidney failure with ADPKD, and there is no family history of cerebral aneurysm or subarachnoid hemorrhage. Blood pressure is not perfect, but not terrible, 134 over 82. He has palpable kidneys, but otherwise his physical exam is normal. His hematocrit is 38%. His creatinine is 3.7. Now, we didn't specifically address this in the lecture, but what do you think in terms of the next step for his evaluation? Should we do nothing? Should we check a carotid Doppler? Should we do an MRA of his head and look for intracranial aneurysms? Or should we send him urgently to get his 4-vessel cerebral arteriography by the neurologist or neurosurgeons? A. Did I hear A? Does anybody agree? Okay, so the answer is A. This is a worried professor who needs to be reassured. Can you think of a person in a profession where you might take this a little bit, pursue this a little more aggressively? An airline pilot. Are you a budding nephrologist? So an airline pilot is a perfect example. Anybody in a high-risk occupation, and certainly somebody with a family history of, my mom was driving down the road when she was 38, and she just for no reason ran off the road and died in a car accident. Or mom died of a stroke. She had no risk factors for stroke, but just dropped dead. No, we didn't do an autopsy. We don't know why. When you begin to get a family history that concerns you and a patient with symptoms, that may make you pursue this a little more aggressively.
Is the pilot high risk because he can crash and kill a plane full of people, or just because of the actual flying? So like maybe
the former, the crashing and killing you and me. Yep. So that's it. I mean, yeah, it's just that he's in a job where many people's lives day in and day out depend on him not having an acute cerebral aneurysm. So that's, yes, the altitude, that's an interesting question though, but as far, I've never heard about altitude making a difference. So, all right, what approximate percentage of patients with ADPKD will be found to have intracranial aneurysms larger than 5 millimeters on non-invasive screening studies such as a CT or an MRA? 5%, 20%, or 40%? 5%. I heard enough fives. Yes, that's the correct answer. Okay. All right, now we're going to get into questions where I actually did give you most of the information to answer the question. You are asked to evaluate a 26-year-old woman with mental retardation because a recent abdominal ultrasound exam revealed cysts on both kidneys. She underwent the study because she was having right upper quadrant pain, and she was suspected to have some gallbladder disease. The other reported findings were a normal gallbladder, somewhat irregularly sized kidneys, 11.5 centimeters bilaterally. You don't know her height, so you don't know if that's large, but that seems a little large, but could be normal size if she's very tall. Patient has, actually we do get her height down here. Patient has no family history of renal disease, but she reports that her 49-year-old father was told that he had fatty tumors in both kidneys 2 years ago, and after that he underwent a colectomy for colon cancer. Physical examination today is unremarkable. Her height is 62 inches, so she's not that tall. Her weight is 112 pounds, her creatinine is 1.3, and her urinalysis is normal. So what of those is the most likely diagnosis? And your choices would be ADPKD, autosomal recessive PKD, von HippelLindau, tuberous sclerosis, or multiple simple cysts. And they're trying to trick you up between 2 disorders. Tuberous sclerosis. That's right. So they're trying to give you this cancer history in Dad, who had the colon cancer, trying to make you think von HippelLindau, but you stuck with the right answer, which is tuberous sclerosis. All right. Blank is one of the earliest and most common manifestations of ADPKD. Yes. 60 to 100% eventually develop hypertension. The choice of antibiotic for treatment of an infected kidney cyst and ADPKD should be based on the results of urine culture and sensitivity and the likelihood that the antibiotic will actually penetrate into the cyst. It needs to be lipophilic, remember. Antibiotics that have been shown to readily penetrate kidney cysts include all of the following except. Say it again? C, ampicillin, right? So you would see this on exam if you didn't really know this or you were guessing. You'd probably guess something else. I mean, it would sort of lead you down a different path. You'd think chloramphenicol, huh? So, but ampicillin is the one that does not penetrate. So the penicillins are no good. So if they were to give you a choice of giving, you know, piptazo, give Zosyn, or give an aminoglycoside, you know, for cidal gram-negative coverage, that's really not what's going to work here. All right, extrarenal manifestations of ADPKD include all the following except. D, right. And do you remember what D goes with? Pulmonary hypoplasia? AR, that's right. So autosomal recessive polycystic kidney disease. They get the hyponatremia and the perinatal diagnosis. And I think do we have any med-peds people here? I think they get like an enlarged calvarium. Does that ring a bell? I mean, there's a number of other things. I didn't go through all those with you, but definitely that is not part, pulmonary hypoplasia is not part of ADPKD. All right, and then the last one, which of the following gene mutations is most frequently associated with renal cell carcinoma or clear cell? Von HippelLindau. Right. So you didn't necessarily have to know all the different specific genes. You just have to remember. They gave you the disorders, so you just had to remember the disorders. So I think that's it. Does anybody have any questions? All right. Again, thank you. Again, these are fairly esoteric, and so right now you're like, oh, I'll never remember this. I never see these diseases. But when you're studying for boards, these are a quick 2 or 3 points on a renal exam. And so just, you know, pull this stuff up. If you ever need a cheat sheet, we have cheat sheets because we use them too for this kind of stuff. And you can get some quick, easy points that way. All right, thanks.
So for those of you that don't want to continue to get the in-basket messages for patients sending stuff in for the MyChart, there is a quick and simple fix for that. In your in-basket, click on Edit Pools, and then you can uncheck the patient advice and patient prescription request pools. Have any questions, email me and I'll email you these directions. Again, I would have shown it to you, but I can't get on to Epic. I just wanted to let you guys know that. Those in ambulatory help clean up until I get back to the services. Thanks, guys.